study design from the point of view that if we don't have good data coming in, there's really no analytic method that can really truly fix that. So starting out with strong study designs in the beginning actually simplifies the data analytic methods and also increases our ability to make causal inferences from our findings. So this was already presented very well by Dr. Zofty, but we talked about the implementation pipeline from efficacy to effectiveness and cost-effectiveness research to implementation research to dissemination research. And I noticed she added a little twist, which I actually think is applicable and actually modernizes this slide, which is that dissemination is essentially maybe precedes implementation, in that implementation might be addressing also scaling up and scaling out of interventions and truly making them a part of the public healthcare system as well as the healthcare system. So as Dr. Zofty mentioned, implementation science and implementation research is an evolving discipline, and as we continue to practice it and gain more experience working on this in different contexts, our theories and our sort of theoretical frameworks about implementation research is also evolving. So this is my favorite slide, and I think this is where I think will inform most of what I discuss from this point on. So sometimes in implementation science we talk about the 3 R's, that implementation research should be rigorous, rapid, and relevant. So rigorous is a lot of where, say, my work comes in. Sometimes people think, oh, this kind of implementation, this kind of research is soft, it's not really science, you know, we're not looking at real questions, and so forth, because we're not doing hardcore discovery research, efficacy research. But actually, from a methodological point of view and from a theoretical perspective, efficacy research is the easiest type of research to conduct in the pipeline. If you're comparing, say, an investigational drug, whether it's efficacious or not, you're able to conduct that in, you know, a highly rarefied study setting with the most highly trained researchers, with large numbers of exclusion criteria to ensure that your patients or study participants are going to adhere rigorously to the intervention. And the analysis is very simple. You just compare group A to group B, say doing a test between the difference between 2 binomial proportions, or a test between 2 sample means. Very, very easy from a methodological point of view. But when we get into implementation research, as Dr. Zofty showed, it's multi-level. There are multiple components to intervention strategy bundles that we're testing. They have many different variations. The studies are conducted in pragmatic settings, in real-world situations with ideally large patient populations, the usual providers in the healthcare system, and so forth. And so to get rigorous results from those kinds of studies actually requires more advanced study designs and more advanced data analysis methods. Rapid is another important aspect. Despite all of these complexities, we're studying important public health questions like ending the HIV epidemic, which I know is a big focus of many people's research here at this meeting, but there's also many other pressing public health questions that can be studied, such as ending the global disparity in maternal mortality, which of course has been improved greatly over the past 20 years, but there's still pockets where there are still big disparities within countries and across countries, or facing the growing non-communicable disease epidemic as populations age and the lifespan lengthens. So when we're looking at important questions such as ending the HIV epidemic, we can't take 20 years to conduct a study. These are issues that are killing people right now, and we need answers right away to what are the best methods to address these problems. So implementation of methods, to the extent possible, should be rapid, and I actually feel it's an area that needs more work, and you'll see when I show some examples of some implementation and hybrid studies I've worked on. policy change before we even finish the study. I don't know if that's happened to people here, but it's happened to me several times already. And then, of course, relevant. The topics that we study aren't driven by what an individual's PhD thesis was, but rather they're driven by what are the important public health questions, what are the interventions for which we have sufficient evidence that we can go on to effectiveness in implementation research. So again, this is repeating in a sense what Dr. Zaki showed, is that implementation studies on designs are different from RCTs, randomized clinical trials, and efficacy research, and that we're guided by theory, models, and frameworks. And I think tomorrow morning, Luke Davis from Yale is going to give an in-depth overview of theories, models, and frameworks remotely. They're multi-level. These intervention implementation strategy bundles, to be most effective, I think we've learned they need to address multiple levels at the same time, which would include the healthcare system, policymakers, organizational leaders, healthcare providers across all the cadres, clients, and their families and social networks. Implementation strategies are dynamic. The processes go through stages in the prevention, screening, and treatment cascade, and I know many people here would know about the HIV prevention cascade, and we just saw the example of the 390s. That's an example of the HIV cascade, and in order to effectively control and end the AIDS epidemic, we need to achieve targets at all three of those points in the cascade. One alone wouldn't necessarily be sufficient, and then the timing of the delivery of interventions are important as well. So as Dr. Zaki pointed out, this has all of these features have implications for study design and lead to us using different types of study designs that are used in individually randomized clinical trials for efficacy research. And in particular, the assignments, as she pointed out, tend to be at the group level. So we randomize to districts, communities, villages, hospitals, facilities, practices, or providers, rather than individual patients. And that has major implications for study design. So here, this lays out kind of a large group of study designs that are used actively in implementation research. And usually when people take biostat classes and MP classes, you might only, well, if you take a biostat class, you would probably only learn about number one in experimental, the RCT. And now you can see below here, there's at least 4 other designs that are more focused on group level assignments. And I'm going to go over some of these to the extent I have time today. Then there's also observational research. So if you've taken an epi class, you've learned about cohort, cross-sectional, case control studies. That's the major study designs in epidemiology. And I'm a very strong advocate, particularly with my background in epidemiology, to not let the perfect be the enemy of the good. And I'll talk about this a little bit later. Oftentimes we simply just can't randomize. There are ethical barriers to that, there are practical barriers to that, and that doesn't mean that if we can't randomize, therefore we can't learn. There's a huge amount that we can learn from what we call observational data, and I think it's come into more interest in the healthcare world now because of the interest in using electronic health records for research. That's pure observational research, just like we do in epidemiology. And when we sample from and use the electronic health records, we're either conducting a cohort study or usually a cross-sectional study or sometimes a case control study. And then some of you might have heard about this area of causal inference, which are methods, statistical methods to make rigorous causal claims from observational data where we haven't randomized. And in implementation research, we can learn from our healthcare systems what variations of interventions and implementation strategies are relatively more effective and cost-effective and have better outcomes in terms of the implementation outcomes that Dr. Zaki went over. So I really want to re-elevate the observational study designs from the point of view of implementation research. And then, interestingly, in the second column, we have the group of study designs called quasi-experimental. And they've arisen primarily in the health economics discipline, because to a large extent, some of this work in implementation research, especially in low and middle income countries, has been driven by health economists. And their study designs have risen to the fore. So if you take a standard epidemiology or biostatistics class in the United States, you might not even learn about these quasi-experimental designs. You have to take like a development economics course or some sort of health economics course. But these designs are also very important and useful. They are the pre-post designs, difference in difference, interrupted time series, controlled interrupted time series, and also regression discontinuity. And if I have time, I'll go over a few of those. And then finally, Dr. Zaki mentioned the hybrid design, and that's become a very important design in implementation research. In fact, pretty much every study I'm working on is a hybrid design. Like, nobody wants to completely throw away the clinical outcomes, even when we focus on implementation outcomes as our major focus. And then also, as Dr. Zaki mentioned, mixed methods designs are very important in implementation research. And like her, my background was pure quantitative, and I've come to learn and realize how important qualitative data are. How can we understand what the barriers and facilitators are to implementation without talking to stakeholders? And stakeholders, as she pointed out, a lot of times people think it was originally used as a term for policymakers, almost synonymously, but in implementation research, there's lots of levels of stakeholders, from the policymakers to clinic directors, to health district leaders, providers across all the cadres, clients and their social networks. They're all stakeholders. And to understand what's working and what's not working in implementation research, we kind of have to talk to all of these people. And qualitative research provides rigorous methods for doing so that are efficient and allow us to extract the necessary information without imposing kind of our sort of pre-existing beliefs onto it. And sometimes surprises come up that can be very beneficial. So for the rest of this talk, I'm kind of going to proceed sequentially through some of these designs. And we'll see how far we get, because like at Yale, I teach a course on methods for implementation and prevention science, and it's a whole semester course, and I cover these are the topics. I don't even cover all of these topics in the course. So this is more to give you all an idea of these different options that you can choose from and what their advantages and disadvantages are. And then you can decide when you're doing your work what option you think might work best. So I just want to make sure, because I think I might have skipped a section. Yeah. So experimental is a synonym for when you're able to randomize. So first I'll go over the randomized design. So we have the individually randomized design, which I'm actually not going to discuss, but I'm going to talk about cluster randomized designs and then step wedge designs. So this kind of schematic diagram shows on the left-hand side, in a simple RCT, we have a pool of people who have been maybe consented to be in the study, and then we simply flip a coin, or the computer equivalent of that, and usually half of them go into the intervention group and half in the control group. But as Dr. Zaki pointed out, most of the interventions and implementation strategy bundles that we're studying must be applied at some sort of group level, like at a health facility level, a provider level, a village or community level, and so forth. And so on the right-hand side, we show that these individuals actually live and exist within these groups. Say, for example, their village. And now we've flipped the computer equivalent of a coin, and we might put half of the villages in the intervention group and half in the control group. Now, why are these randomizations important? You may have learned in epidemiology that a major source of bias in health research is what we call confounding. And that happens when say the experimental group and the control group are different with respect to risk factors for the outcome. So if we have confounding, in the absence of the intervention, we might see a difference between the intervention and the control group that has nothing to do with the intervention. It just had to do with the people who chose the intervention are healthier to begin with, and so they have better health outcomes. And the people who chose not to participate in the intervention are less healthy, and so they have poorer outcomes. That's an example of confounding. But when we randomize, then we're mixing that all up, and we should expect, on average, half of the intervention group to be, quote, healthy and half not, and half of the control group to be healthy or not. And then when you average that all out, the only thing left to describe the difference between the groups is the intervention itself. And so that's why we love randomization, when we can do it. And in a well-conducted randomized trial, we can make causal inferences straight away without any additional assumptions or analytic methodologies. So that's a cluster randomized trial. And I'll give you an example of one from a public health setting that I worked on. Before being at Yale, as it was mentioned, I think I had been at the Harvard School of Public Health for many years, and this study was conducted while I was there. It was called the Familia Salama Study, and it took place in Dar es Salaam, Tanzania. And I'll just bring up another design feature that we used here that is useful that you may wish to consider in your future research, which is a factorial design. And what that means is you can actually study multiple interventions, multiple completely different interventions, like you're conducting 2 or 3 different studies in the same data set. And the way you do that is by balancing who has intervention control versus intervention group for factor 1. They're balanced with factor 2. And so you can just group all the data and study factor 1, and then group all the data and then study factor 2. So you get essentially 2 for the price of 1. Then you might say, well, why not do 100? Well, you could technically or theoretically, but what happens logistically, and you'll see in this example, it's not easy to do these things in practice, especially when we're doing effectiveness and implementation research at a large population scale. Just rolling out a study and getting, so to say, half in some sense of the units to take up and implement a new implementation strategy bundle with fidelity can be a major effort to get started and sustain. And then if you think of doing multiples at the same time, it quickly becomes not really feasible. But anyway, we did do 2 in this one. We looked at an enhanced community health worker intervention versus standard of care to improve adherence to the World Health Organization's recommendation that pregnant women have at least 3 antenatal care visits before delivery. And that's an evidence-based intervention. They have all kinds of reports and documents about this. And it was something that was not happening on a regular basis in Dar es Salaam. And the second, which had the HIV aspect, was we were comparing option A versus option B for the prevention of maternal to child transmission of HIV among HIV-positive mothers. So we're able to look at both of these at the same time in this study. So here we'll show the example of the clustered randomization with the factorial design. So this was a very large study. It took, the study population included all pregnant women essentially living in 2 of the 3 districts of Dar es Salaam, and they were randomized to one of the 4 arms in this trial. So there were 60 wards in these 3 districts, and then it turned out 36 were randomized to community intervention, community health worker intervention, and 24 to the standard of care. And then the 36 wards were then randomized again. So 22 received option B, 14 option A, and so on. And then you might say, well, why aren't they exactly balanced? So this points, why aren't the same number of wards in each group? Well, this points out what's so interesting and more complex about doing implementation research is that the wards, these are the real wards in Dar es Salaam. They don't all have 15,000 people in them. There's a huge variation in the wards. Some are peri-urban, some are densely urban, and so forth. And so in order to try to balance out the population size that was receiving the intervention or not of these 4 different combinations. With the ward structure, we had to use an imbalanced number of wards. And now this study was done, the design was done quite a while ago. The methods for taking into account cluster randomized trials when you have what we call sort of unequal cluster sizes are much better now than when we were first developing this study. And then another interesting thing happened, which you might see when you do large-scale research. You can see that we expected about 78,000 women who could potentially be receiving option A, and then we expected 78,000 versus 81,000, but what we observed was 89,000 versus 98,000. So we actually had a much bigger sample size than we had expected, and these sorts of things happen in real-life study planning as well. In efficacy research, they usually have trouble recruiting people, and they don't have the sample size they need, and sometimes studies are stopped because of the failure to recruit. But in this sort of population research, it turned out there was demographic census data, but Dar es Salaam is a dynamic, modern city. There are people continuing to flow in from outlying areas. There was undercount and so forth, and so there just turned out to be a lot more women delivering babies in these districts, quite a lot more than had been expected. And it's kind of interesting that by doing this research, we learned something about the demographics that the standard demographics weren't even telling us. Another thing that happened was we weren't sure what the HIV positivity rate was among pregnant women. So we used data from Botswana for our projections. And it turned out that, as we all know, the AIDS epidemic has declined dramatically, and had also in Dar es Salaam. So I think we projected something like 6% HIV positive pregnant women, but it turned out, luckily and very happily, it was only 2%. So then it was like, oh my God, we're not going to have enough power for our study. But then in the end, as you can see, because there were so many more women in these 2 districts, it all balanced out in the end. That was just luck. But this is an example of how the challenges in actually planning studies in real-life population settings at scale, and the different issues that come up. And then we did publish some results, and we found that the intervention, community-enhanced community health worker intervention, increased the likelihood of attending 4 or more ANC visits by around 40%. And it had a modest effect on the total number of visits, but we weren't able to improve the timing of the first visit. Ideally, as many of you know, we like women to come in during their first trimester, and that did not happen sufficiently in this study. So the next design is the step wedge design, and that's something that has become increasingly popular in implementation research. In fact, pretty much, in addition to almost every study I work on being a hybrid type 2 study, almost every study I work on is also a step wedge design. Everybody wants to do step wedge designs. So this is a schematic of what the step wedge design looks like. And the randomization happens not whether, so let me say, what we have on the rows are clusters. So in this, they're patterns of clusters. So in this diagram, there are 5 patterns. There could be 3 clusters, say 3 hospitals in each one of these, or it could be only 1. But it has to be at least 1, otherwise this wouldn't make sense for that particular study. So it's the patterns of clusters that are being considered, and then the columns are the time periods. So this study has 6 time periods and 5 patterns. And what we do is randomize, say the first cluster, say the first hospital gets randomized, and maybe they're assigned to pattern 4. So that means that they're in standard of care until time 5, and at the start of time 5, they take up the intervention. And then the next hospital comes in and they're randomized to pattern 2. So they are in standard of care for 2 periods, and then period 3, they start the intervention. And one of the advantages of this design is, as you can see, by the end of the study, all of the clusters have the intervention. And don't forget, as Dr. Zaki pointed out, we're studying evidence-based practices. We're not experimenting on things that we don't know if if they're going to work or not, if they're delivered effectively and properly, they will have their benefit. We know this already. So then how can we say we're in equipoise and we can randomize, say, half the villages to not getting an evidence-based intervention for, say, 2 or 3 years, and then the other half having it? You know, a lot of people are uncomfortable with that. So when you use a step wedge design, there still is a withholding, but by the end of the study, everybody, all the clusters and everybody in them will have this intervention, whether it worked or not in practice. Some of them get it quite soon, so that's also a good thing. The other thing about step wedge that I think people like is, for those of you who have conducted implementation research, and as we've discussed, the interventions are often complex and multi-level. It's not just getting a pill into a facility and giving every other person from one bottle or the other. They're very complicated. So you can't really start everywhere at once, especially in a large effectiveness trial. You've got to kind of go to maybe the first 1 or 2 hospitals, get it going, and then 3 months later you can move on and train people in the next ones. So it's kind of, even if you weren't even doing a study, and the Ministry of Health decided that this was a program that should be taken up in a country or an area, usually you have to kind of start somewhere and then move on and train the next group and then move on. So you're kind of, that's an observational step wedge design in a sense. So where we get the, so those are some of the practical reasons I think why it's popular. And and from the sort of theoretical and methodologic point of view, what we see is because groups were randomized to the clusters, at each time point we have a randomized comparison. So at time 2, we, cluster 1 and group 1 was randomly given the intervention, and then groups 2 through 5 were randomly not given the intervention. So that's just like a cluster randomized trial. And then time 3, now we have 2 that were randomly assigned to the intervention and 3 that weren't. So each one of these time points where there's variation, we actually have a cluster randomized trial. And we just have a whole set of them that we can combine together to analyze in the end. So we get that causal inference, experimental nature. And then in addition, if you look across the rows, what we have is 5 different quasi-experimental designs, pre-post designs, where, say, in the first row, we had standard of care data in period 1, and then intervention data in period 2 through 6. So now that's not randomized. That's why it's called quasi-experimental. But what we have is the pre-post type of contrast, where as within a facility, the facility is constant with, as long as the facility is constant with respect to all of the factors that influence the outcome. I'm going the wrong way. With respect to all of the factors that influence the outcome, you have a causal contrast. It's like a paired t-test in the simplest case. And so the only thing we have to worry about is background factors changing that might also influence outcomes at a given facility over time, independent of the fact that the facility took up the intervention at a certain point in time. So does anybody have any questions about the step wedge design? Because that might be a little new to some people here, but because of its attractive features, it's very popular. And we can maybe we'll have time for it. So now I'll go over a study that I worked on that used this design. It was called Early Access to ART, and it took place in Swaziland, which is now called Eswatini, and it was funded by the Clinton Health Access Initiative and the Dutch Postal Code, as well as the Ministry of Health of Swaziland, and it was exactly a step wedge design where we had on the rows, we had 7 time patterns, we had 14 facilities, and they were randomly assigned to start at one of these times. So the little C's mean that was all the intervention time, and then the little I's were, the little C's was the control or standard of care time, and then the I's were the intervention time. And the purpose of the study was to look at the impact. I think Dr. Zaki also mentioned this too, about sort of the global effort for everybody to start on ART as soon as they test positive, regardless of their symptoms. And this was very early on in the, or even before this policy was issued. And the it had already been shown, I think, really, what I'd probably call efficacy research, that early access to ART reduced transmission and was thought to be a way, was predicted to another way to end the AIDS epidemic. But it hadn't really been looked at, what is the impact of early access to ART on the HIV positive people themselves, whether it could lead to drug resistance so that they would be less responsive later on when their disease developed, or whether it would lead to more non-adherence, or maybe it would be very beneficial for them, and that hadn't been looked at. So that was the purpose of this study, although as you can see, it was just a short-term study, like 2.5 years, 3 years. So we really couldn't look at the long-term impact. We could only look at the short-term impact. And then, as I mentioned about rapid, sometime in maybe, I'm sorry, I don't have a pointer or anything, but towards the later end of the study, about a year before it ended, WHO adopted the early access to ART policy, and the Ministry of Health of Swaziland immediately switched. So that was the end of all these control periods. Everybody switched on to the intervention. And it wasn't terrible. It just made the study imbalanced and had less statistical power. But that's an example of being able to conduct rapid research on these important policy questions is so essential. And that was true in Familia Salama too, I forgot to say, that the option A versus option B issue, when the study started, it was an equipoise, and the WHO guideline was countries should do what they thought best. Of course, nobody knew what was best. As before the study ended, WHO recommended option B, and all of the facilities that were randomized to option A switched to option B. So, if we want to have an impact of our research to determine policy on some of these questions, is getting things done, getting the research done more quickly is extremely important. Yes? Oh, great. So anyway, we did find that there was a benefit on retention, a 60% increase, and on retention and virus suppression combined. We also found that there were major issues in measurement of reporting back of viral loads. So in terms of step wedge designs, when, as I mentioned, one might choose one relative to a cluster randomized trial. When there's evidence in support of the intervention already, there would always be an implementation research, and resistance to a parallel design where only half receive the treatment. Also, maybe when the treatment is service delivery or policy change, it does not need participant consent, because you conduct the research on the facility level and so forth, and individual consenting can be rather difficult at times. When the intra-cluster correlation is high, the step wedge design can be more statistically efficient as well. And what I mean by the intra-cluster correlation is when facilities have similar outcome rates. So let's say retention is, say, 60% in one facility, but only 20% in another, and so forth. And that creates that people are more alike within their facility than between facilities. And that causes a big drop in statistical power in parallel cluster randomized designs. And the step wedge design, because it's able to do that pre-post comparison as well and use the within cluster comparisons, is much less, power is much less adversely affected by similarities within groups. And then we have some cautions, and maybe I'll just skip over those for now. And how am I doing on time? When should I be aiming to end my talk? It's 20 after 10. great. So we talked about if you can't randomize, and I've kind of already discussed it, and why is that useful? Because randomization and doing this kind of deliberate research is very expensive. And so using the data that we have, I really encourage people to do. It's well worthwhile. And there's a bunch of papers, like implementation scientists have discovered, have rediscovered observational research, and now written papers in their own literature about things we've known about in epidemiology for years. So here's an example of a study I worked on. It was called Casalud Towards a Learning Mexican Public Primary Healthcare System. And what the interest here was in diabetes detection and control. And again, it's a very large at-scale study that involved all of the electronic health record data in Mexico across a certain period of time from June 2016 to July 2018. It involved almost 2 million patients and over 12,000 health facilities. I'm not sure what the electronic health record data situation is in Malaysia, but I hope over the next 3 days to learn about that. And before even any interventions could be conducted, there was just interest in what's going on in the health facilities in terms of diabetes detection and control. So a scoring system was developed called ICAD. It was an index for the quality of care for the prevention, screening, and treatment of diabetes. And in these data that I'm showing you here, the unit of observation is one facility month. And what this is we calculated the ICAD score for every facility across I think there's 32 states in Mexico over this time period. And then we just plotted we plotted the change in the ICAD score between 2016 and 2018 to see if there have been any improvements in NCD care. And so the rows are all the different states. And then what we have, and then the x-axis shows what the mean ICAD score was for each one of the states, as well as its range, the change in the score. And so what we see, and you may see this in Malaysia as well, major health disparities. Certain states had big improvements in NCD care, and others actually got worse. And they could be ranked. And so then in terms of implementation research, this would lead to a number of different actions. For one, from a sort of health equity point of view, we might focus on those states where there was actually declines in diabetes care over this 2-year period. And then what we might learn from the states that did really well, we might do mixed methods and especially qualitative research to figure out what's going on in these states where they're doing a really good job and made these big improvements. What are they doing? And then how can we translate those, local implementation strategies into the areas where they're having a really hard time with this sort of thing. And so it would just go from there. This is just pure observational descriptive data from the electronic health records that has major implications for the control of NCDs in Mexico. Now I can go on to quasi. That was just one example of an observational study and its implications for implementation research. And now I can go on to quasi-experimental designs. So I kind of talked about pre-post when I showed you the step wedge design, because every time pattern in the step wedge design is a little mini pre-post design where we can actually estimate the effect of the intervention just from that one facility by looking at the outcomes before the intervention started and after. We might have a problem with statistical power, but we can certainly estimate an effect. And then the major issue, as I mentioned, with pre-post designs is the fact that there can be time-varying factors in the background that might lead to changes in facilities that have nothing to do with the intervention. And there's a very famous example of this, which has to do with the, I think it was called something like the Millennium Villages Project that was conducted by Jeff Sachs and others in Colombia in a number of sub-Saharan African countries where they went in and threw all of possible interventions to improve health into certain areas. implementation strategy. But then after it was all published, some other people went in the background and looked at what happened in similar areas in the same countries and even different countries where there was no intervention. And guess what? Their health status improved a lot also. The whole world is actually getting healthier. And it was unclear whether the implementation strategies that were conducted by the Planning the Village project, that was the pre-post design, initially said, wow, yes, this is incredible. And then with the controlled pre-post design, it was like, well, maybe not. There's things going on in the background that are improving health that have nothing maybe to do with these health interventions. So next I'll talk about an interrupted time series design. It's another really excellent quasi-experimental design that can be used in terms of rapid. This is one that can be done very rapidly because what happens is what we have on the y-axis is the outcome measure, and then the x-axis we have a period of time before the intervention where we measure the outcomes. If it's only one time, it's a pre-post design. If you have lots of times, it becomes an interrupted time series. And then the causal counterfactual is that the intervention comes in, and that's the dotted line parallel to the y-axis. It comes in, and if there's no effect, the observed outcome rates would just continue at what they had been before. But if the intervention has an effect, we're going to see a drop. Let's say if this is a health promotion program of some kind, we're going to see a drop in the outcomes if the outcomes are adverse health events. And then we might even see a continuing trend where things continue to improve. And so by estimating this drop and then estimating the slope, we can quantify the impact of this intervention from a quasi-experimental point of view. And it has the same problem as a pre-post design, which is this counterfactual, what if health was getting better anyway? So after the intervention came in, even in the counterfactual group that didn't have it, you'd still see these improvements. That's the thing we don't know. And so we can have a controlled interrupted time series where maybe there's some other districts or areas where the intervention isn't happening, and we can get some sense to control for these possible time effects. And so I think I just have like 1 minute. I was going to show you, I'll just show you this graph. So we conducted an interrupted time series study in the United States, and what we wanted to look at was the impact of the Affordable Care Act, which is our enhanced national health insurance program that was brought in by President Obama and is still, believe it or not, in place in the United States right now. And one of its very positive features, it included support for a number of preventive health measures that were evidence-based, and an important one is colonoscopy, or screening for colorectal cancer, which is very expensive in the United States. To receive a colonoscopy screen is like, at this point it's probably $3,000 or more per screen, although now there's some other methods of doing this that are less expensive. So what we wanted to see was the Kaiser Health System, again, using their electronic health records. The red line is the point at which Obamacare came into place in the background, and then Kaiser, along with all other health systems, had to start providing colonoscopies to all of the people enrolled in this health insurance plan for free. And so we have expected an increase in colonoscopy rates and so forth. And so on the left-hand side up to the red line, you see these are the colorectal cancer incidence rates in Kaiser. And they're just kind of going up and down, but really basically the best description is a flat line, no change. Possibly even maybe increasing a little bit. And this very jagged line is actually the monthly rates. And so for those of you who studied epidemiology, this is the kind of natural variation we see in rates just due to fluctuations that occur. And then you can smooth those through statistical methods. But then when Obamacare came in, it was really kind of amazing. I almost felt like, gosh, are we committing data fraud? Because it exactly followed the pattern of, where is it? It exactly followed the schematic pattern of the interrupted time series designed from a textbook, where we saw a very quick drop in colorectal cancer incidence, and then we continued to see a decline in the rates. So that was very satisfying. This was the paper. And so there's some other designs. I'm going to give a talk on Wednesday morning on on the learn-as-you-go design, which involves being able to, in a complex, multi-level, multi-component intervention, to adapt the strategy as you go along using the existing data. So you're not stuck with a single complex package at the beginning. And that's some new work that we're doing in our group that I'm very proud of, and I'll illustrate it by an example of a study going on right now in Uganda where we're integrating hypertension prevention, screening, and treatment into HIV clinics. And that's something that's happening throughout sub-Saharan Africa right now, and maybe happening here as well. So I'm not going to say anything more about it, and I'm just going to maybe go to I also have much of things I could say about hybrid designs, because as Dr. Zaki pointed out, what's different statistically about hybrid designs, especially hybrid type 2, which is the one that most people want to do, is that you have a clinical outcome or a health outcome, and you have an implementation outcome as a primary outcome. And you have to power your study to be able to detect these two primary outcomes. Well, it turns out there's 5 different statistical methods that can do that. Some of them haven't been adapted to cluster randomized trials. So it's a very active and interesting area of statistical research. And I have an example of that, but I'm going to just lead to my take-home points that, very similar to Dr. Zaki's, implementation studies require consideration of context, multiple levels, multiple components, timing matters. I've given you a kind of, I've put on the table, some in more detail, some in less, of many study designs that can and are being used for implementation research, and you can identify and rank them given the needs of your group, your budgets, time factors, and other things, and then decide. You can consider randomization when possible to increase causal rigor. You can consider innovative approaches, which I didn't have time to go into really, some of the more innovative approaches. And then, as I mentioned, if randomization is not possible, there are rigorous quasi-experimental and observational designs available. And this is the focus of causal inference. Let's not let the perfect be the enemy of the good. So thank you very much.
Donna Spiegelman. As we are pressed for time, if you have questions for Professor Donna Spiegelman, you can discuss with Professor Donna during the lunch break. Let's take a few minutes to have tea and coffee now. Tea and coffee has been served outside. Please feel free to get your tea and coffee and reconvene here in a few minutes of time. See you in a few minutes. Thank you.